Welcome back to the deep dive. Today we're tackling adrenergic-blocking drugs, basically chapter 20 from Lilley's Pharmacology. We want to give you a really clear roadmap. Yeah, our mission today is pretty simple. Break down the core concepts for alpha blockers and beta blockers. We're talking mechanisms, uses, and, the really critical clinical stuff you need to watch out for. It's more than just facts. It's about understanding why these drugs are so important and sometimes risky.
Exactly. And let's start with that core idea. Adrenergic blockers are often called sympatholytics. Think about that word. Endolytic, it means to inhibit, to break down. So these drugs, they fundamentally put the brakes on the sympathetic nervous system, the SNS.
The fight or flight system.
Right. They do the exact opposite of adrenergic agonists,
Yeah.
which you might have already covered.
Yeah.
Agonists stimulate. These blockers inhibit.
Okay, so let's set the scene. We know the SNS uses key messengers, norepinephrine and epinephrine, and these messengers, they fit into specific locks, the adrenergic receptors. Knowing these is crucial.
Absolutely crucial. You've got alpha-1, alpha-2, beta-1, and beta-2. Location is everything here.
So walk us through that. Where are they?
Okay, alpha-1 receptors. Think postsynaptic effectors, cells, muscles, tissues. Stimulate these, and you get things like vasoconstriction, blood vessels tightening up.
Right, so blocking them would do the opposite.
Precisely. Blocking alpha-1 leads to vasodilation. Then there's alpha-2. These are a bit different. They're usually on the presynaptic nerve terminals. They kind of act like feedback inhibitors, telling the nerve to release less norepinephrine.
Okay, inhibitory. And the betas.
This is where it gets really important clinically. Beta-1 receptors, remember B1, one heart. They are almost exclusively on the heart. Blocking these reduces heart rate, force of contraction, slows things down.
Got it. B1, heart.
Then beta-2. B2, two lungs mostly. They're mainly on the smooth muscles of the bronchioles and also blood vessels. Blocking beta-2 receptors is what causes that big side effect risk. Bronchoconstriction, difficulty breathing.
Okay, so the basic idea is these drugs are antagonists. They jump onto the receptor site and just block the normal messengers from doing their job. And we group them based on which receptors, alpha, beta, or sometimes both they hit.
That's the framework.
All right, let's dig into the alpha blockers first. If beta blockers are about the heart rate, maybe alpha blockers are more about the blood vessels, the plumbing.
That's a good way to think about it. They primarily interrupt the SNS at those alpha-1 receptors we talked about.
And how exactly do they block them? Is it just one way?
Well, the textbook mentions two main mechanisms. The most common is competitive blockade. The drug molecule basically just crowds out norepinephrine, competes for that receptor spot.
Okay.
Less often you might see non-competitive blockade. This is stronger. The drug might form a really tight, maybe even covalent bond. It essentially takes that receptor out of action for a while.
But either way, the end result is blocking that alpha-1 signal.
Right. And the effects follow from that. Vasodilation, both arteries and veins relaxing. This lowers systemic vascular resistance, so blood pressure drops. You also see meiosis pupil constriction and, importantly, relaxation of smooth muscle in the bladder and prostate.
And that relaxation is key for their uses, right?
Definitely. So you see alpha blockers like doxazosin or terazosin used for hypertension because of the vasodilation. But then you have drugs like tamsulosin and alfuzosin, which are real workhorses for benign prostatic hyperplasia, BPH.
How do they help BPH?
By relaxing that smooth muscle at the bladder neck and in the prostate, they reduce the obstruction, making it much easier for men to urinate. It can be a huge quality of life improvement.
Okay, but there's a specialized one too, isn't there? Phentolamine?
Yes, phentolamine is really interesting and vital in certain situations. It's used for the crazy high blood pressure you can get with a pheochromocytoma, that rare adrenal tumor pumping out adrenaline.
Wow, okay.
But maybe even more critically, in day-to-day hospital settings, it's the antidote for extravasation of vasoconstricting IV drugs.
Extravasation. That's when the IV leaks out.
Exactly. If a drug like norepinephrine leaks into the surrounding tissue, it clamps down those blood vessels so hard it can kill the tissue, cause necrosis. Injecting phentolamine right into that area can reverse the vasoconstriction and actually save the tissue. It's a rescue drug.
That's incredible.
Yeah.
But with all this vasodilation, there have to be downsides. Dropping blood pressure sounds like it could cause problems.
Oh, absolutely. The big one everyone worries about immediately is orthostatic hypotension. That dizziness or faint feeling when you stand up too quickly because your blood pressure drops.
Pretty common with blood pressure meds, yeah.
Yes, but alpha blockers can be particularly potent. And the most critical thing to warn patients about is the first dose phenomenon.
What's that?
It's a potentially severe, really sudden drop in blood pressure right after taking the very first dose of the drug. It can cause fainting, falls, It's a major safety concern.
So what do you tell patients? How do you manage that risk?
The standard advice, and this is crucial, is to take that very first dose right at bedtime while lying down. That way, if the big drop happens, you're already horizontal and less likely to fall and get hurt.
Makes sense. And any other major reasons not to use them? Contraindications?
Well, the obvious one is a known allergy. Also, generally avoided in peripheral vascular disease. Sometimes severe liver or kidney disease needs caution too, or peptic ulcers. It depends on the specific drug.
Okay, let's switch gears then. Let's talk about the beta blockers, the heart protectors.
Right. These compete with norepinephrine and epinephrine too, but at the beta receptors, B1 and B2, they're all about slowing down the heart and reducing its workload.
And you mentioned selectivity is key here.
Hugely key. You have cardioselective beta blockers. These primarily target those beta-1 receptors on the heart. Think drugs like Atenol, metoprolol. They slow the heart rate, decrease how hard it pumps, and reduce the heart's oxygen needs without messing too much with the lungs.
Okay, so B1 selective for the heart. What about the others?
Then you have the non-selective ones, like propranolol. These block both beta-1 and beta-2 receptors. So you get the heart effects, which you want, but you also block beta-2 in the lungs.
And that causes
Bronchoconstriction, tightening of the airways. That's why non-selective beta blockers are generally a big no-no for patients with severe asthma or COPD. It can trigger an attack.
That's a critical distinction. Are there other types too? I think the text mentions some quirks.
Yeah, there are a couple of other categories. Some have intrinsic sympathomimetic activity, or ISA, like ascotrol. These are weird. They partially stimulate the beta receptor even while they're blocking the main neurotransmitter.
Oh, you want that.
It might be helpful for patients who can't tolerate the really profound slowing of the heart rate you get with other beta blockers. It provides a bit of a buffer, less intense bradycardia. It's kind of a niche thing.
Interesting. And the combo ones?
All right, the alpha-beta blockers. Labetalol and carvedilol are the main ones. They block alpha-1 receptors and beta receptors. So you get vasodilation from the alpha blockade, plus the heart rate control from the beta blockade. Very useful for tricky hypertension or heart failure.
Okay, let's talk uses. You called them cardiac protectors. What's the biggest use case?
Undoubtedly, post-myocardial infarction, MI, post-heart attack. Giving a beta blocker, especially a cardioselective one like metoprolol, after an MI has been shown to significantly increase survival.
How does it help after an MI?
After a heart attack, the body releases a flood of catecholamines, adrenaline, which can overstimulate the already damaged heart. Beta blockers shield the heart from this surge, letting it rest and heal, reducing the risk of fatal arrhythmias. Metoprolol is a star player here.
Makes sense. What else are they used for?
Lots of things.
Yeah.
Chronic stable angina chest pain because they reduce the heart's oxygen demand. Certain cardiac dysrhythmias because they slow conduction through the heart's electrical system. Hypertension, obviously. And even migraine prevention.
Migraines.
Some beta blockers, particularly propranolol, are quite lipophilic, meaning they like fatty tissues and can cross the blood-brain barrier easily. The exact mechanism for migraine prevention isn't perfectly understood, but it seems to work for some people.
And heart failure. I thought they used to avoid them in heart failure.
They did. It seems counterintuitive to slow down a weak heart. But large studies show that certain beta blockers, specifically carvedilol and metoprolol, when started at very low doses and increased very slowly, actually improve survival and slow the progression of chronic heart failure. It's about protecting the heart from that chronic overstimulation.
That's a big shift in thinking. Okay, let's go back to the non-selective ones and the risks. You mentioned the lungs, but what about patients with diabetes?
Yes, this is absolutely critical for patient teaching. Non-selective beta blockers can be problematic for diabetics for two main reasons. First, they can blunt the body's ability to recover from low blood sugar hypoglycemia, but even more dangerously, they mask the warning signs of hypoglycemia. You know, the shakiness, the rapid heartbeat, the sweating. A patient on a non-selective beta blocker might not feel those signs, so their blood sugar could drop dangerously low before they even realize it.
That sounds incredibly dangerous. They wouldn't know to eat sugar or get help.
Exactly. They might just suddenly become confused or even have a seizure without the usual warning symptoms. That's why cardioselective agents are generally preferred if a diabetic patient needs a beta blocker. And you need intense patient education about monitoring blood sugar extra carefully. They also might slightly impair insulin release, contributing to hyperglycemia.
Wow. Okay, so quick recap on key players. Propranolol, the classic non-selective, watch out for the lungs and blood sugar masking. Metoprolol, the go-to cardioselective, great for post-MI. What about esmolol?
Esmolol is different. It's very potent, very short-acting, and given only by IV infusion. It's a high-alert medication used in critical care or surgery to rapidly control certain fast heart rhythms, specifically supraventricular tachydysrhythmias. Its short half-life means you can turn it off quickly if needed.
Okay, got it. High alert, short-acting 5. This all leads perfectly into the practical side, the nursing considerations, the clinical stuff.
Absolutely. These are the non-negotiables before you give any of these drugs, especially beta blockers. You must do a thorough assessment.
Meaning?
Meaning, check the blood pressure both lying down and standing up to check for orthostatic changes. And crucially, take the apical pulse for 1 full minute. You need an accurate heart rate.
And there are hard stops, right? When you hold the dose.
Yes. The standard parameters are hold the beta blocker if the apical pulse is less than 60 beats per minute, or if the systolic blood pressure is less than 100 millimeter Hg. You absolutely need to check those before giving the dose. And always check for underlying conditions like asthma or severe heart failure that might be contraindications.
Okay, now, for what might be the single most important teaching point for anyone taking these medications.
Yes, the big one. Patients must be taught to never abruptly stop taking their adrenergic blocker, whether it's an alpha or a beta blocker.
Why is stopping suddenly so bad?
Because the body has adapted to the drug being there. If you suddenly remove the block, you can get a massive surge in sympathetic activity. This can cause severe rebound hypertension, blood pressure shooting dangerously high.
And for beta blockers?
It's even riskier. Suddenly stopping a beta blocker can precipitate angina, arrhythmias, or even a myocardial infarction. It's potentially life-threatening. If the drug needs to be stopped, it has to be tapered off slowly, usually over 1 to 2 weeks, under a doctor's supervision.
That message needs to be loud and clear. What other safety teaching?
Reinforce the basics. Change positions slowly to avoid that orthostatic dizziness. If they feel dizzy, sit or lie down immediately.
Makes sense.
Also, daily weight monitoring is often important, especially with beta blockers used for heart failure. Tell patients to report a weight gain of 1 kilogram, about 2 pounds, in 24 hours, or 2.3 kilograms, about 5 pounds, in a week. That could signal fluid retention.
Okay, good tip. Anything else specific?
Yes. For patients on alpha blockers for BPH, like tamsulosin, they need to tell all their healthcare providers, especially dentists and surgeons, before procedures. There can be interactions, particularly something called floppy iris syndrome during cataract surgery.
Right. Full disclosure is key.
And finally, general lifestyle advice. Avoid things that cause excessive vasodilation and could worsen hypotension or lead to fainting heavy alcohol use. Really strenuous exercise in hot weather, hot tub, saunas. Moderation is important.
So when we're evaluating, what are we looking for?
You're looking for 2 things. One is the drug working. Are we seeing the therapeutic effects, lower blood pressure, slower pulse, less angina? And 2, are there adverse effects? Watching for bradycardia, low blood pressure, fatigue, sometimes even depression with beta blockers. It's that constant balance.
That really covers the clinical application well. Okay, let's do a super quick wrap-up.
Sounds good.
So adrenergic blockers, also called sympatholytics, work by blocking the effects of the sympathetic nervous system. Alpha blockers primarily cause vasodilation, think plimming. Beta blockers primarily slow the heart, think pump control. Selectivity, especially with beta blockers, is critical.
And maybe the final thought to leave you with, connecting back to that crucial teaching point, given the serious danger of rebound hypertension or even heart attack if these drugs are stopped abruptly, perhaps the most vital intervention isn't just giving the pill correctly, but ensuring the patient truly understands why they must never stop taking it without medical guidance. That non-pharmacological piece, the patient education on adherence and tapering, is just as life-saving as the drug itself.
A really powerful point to end on. Understanding the why is just as important as the what. Thank you so much for breaking that down for us. And thank you all for joining us for this deep dive into adrenergic blockers. We'll catch you on the next one.